Thank you, Min, and thank you for the organizer for inviting me. So I'll be talking about CT revascularization in the context of multivessel disease. Those are my disclosures. Learning objectives, we'll look at the options for patients with multivessel disease in the presence of a CTO. I'll talk a bit about the limitation of vein graft for the CTO, and we'll propose an algorithm for multivessel revascularization in the context of CTO. In the Canadian registry, you see that CTO were found in about 18% of patients. In terms of PCI, there was a successful PCI of CTO in about 7%. Coronary bypass grafting was done in 26%, but actual bypass was done in 23%, just to give you some numbers. In syntax, there were some CTOs, there were 543 CTOs, and in the cabbage arm of syntax, you see that the success rate, the bypass cases were about 68%. And the non-bypass CTOs about 32%. And several reasons were listed for not bypassing, essentially if the vessel was too diseased, insignificant vessel, inadequate chondry, but it was not specified in a large majority of cases. So it's important to understand the relationship between CTO and syntax because a CTO is a driver of a high syntax score. There's a lot of factors that goes into the syntax score, but a CTO actually gives you kind of almost like 5 times more points than a single lesion, and some points are added if according to the age, if there's a blunt occlusion, if there's bridging occlusion as well. In terms of the location of the CTOs in syntax, you see that most of them were in the RCA, most in the mid-RCA, and in terms of left-sided CTOs, they're all in the single digit. You see the proximal LAD was 4.8%. So just to give you a little bit of a context of CTO and syntax. In terms of completeness of revascularization, this manuscript is about the completeness in the group in syntax that had a CTO. So basically, whether you look at the patients, whether they had PCI or cabbage and a CTO, in green is the completeness of revascularization, and they basically did better in both groups with complete revascularization compared to incomplete revascularization. Now, one of the reasons for maintenance of incomplete or recurrent incomplete revascularization is vein graft failure. And this is a PREVENT-4. This is probably the strongest data we have on vein graft failure at 1 year. This is 10 years old. And essentially, vein graft failure is in the order of about 25 to 30% at 1 year. Another study that looked at that was a PRAG-4 trial. This was an on-pump versus off-pump cabbage, but they did have a 1-year angiographic follow-up. And they showed that about vein graft failure in about 50% of the cases. But what's interesting in PRAG-4 is that we have information about vein graft failure to a CTO vessel. And if the CTO is the LAD, all of those patients got a lima, and the patency is 100%. But if the CTO is elsewhere, essentially there's about a 25 to 24% patency. So that's like above 70% failure rate of a vein graft to a CTO vessel. So that's the information we got from PRAG-4. Another trial here, this is interesting because it gives you another relationship between CTO and cabbage, is that cabbage often leads to CTO. This is the RASP trial from our colleagues in Toronto, a study of the radial artery chondry for bypass. And they show that if the pre-cabbage stenosis was more than 90%, there was a 45% chance of that vessel being a CTO. So there's a kind of a funny interplay between CTOs and cabbage or vein graft, is that CTO is often a driver to perform cabbage, but cabbage also causes, vein graft causes CTO. So this is the algorithm, and I'm going to go through the multivessel side of the algorithm. If you have CTO and multivessel disease, the first thing you should look into is, what is your goal? Is the goal complete revascularization, or if incomplete revascularization is acceptable? In terms of if the goal is complete revascularization, well, you look at the syntax score. If it's at least moderate to high, you should probably consider cabbage. If it's a low syntax score, there's other things you look into. You look into the complexity of the lesion, whether the patient is diabetic, the LV function, and if there is mini invasive bypass at your center. Classically, we would do the CTO PCI first. Okay? And then if it's not successful, then the patient can be referred to CABG. But nowadays, that we do complex CTO by using the contralateral side, often you have to treat the donor artery in order to make the CTO PCI safer. So very frequently, we will do the PCI of the non-CTO first, and after that, well, you've got to do the CTO PCI. Basically, you want to complete your goal, which is complete revascularization. If you've got an elderly patient, comorbidities, and incomplete revascularization is acceptable, then you can certainly start with a non-CTO PCI first, and then you reassess for symptoms, ischemia, and if need be, you can do the CTO PCI. I'll give you some cases here. So basically, you've got a gentleman here that has a circ lesion. There's a CTO of the RCA. This is a single injection film first. And he's got a diffuse disease, RCA. So this is a gentleman that was an older gentleman. He did not want to have CABG. This was presented to me by a surgeon, and the surgeon asked me if I can have complete revascularization for this gentleman. And the answer was yes. So first what we did here, we see here the injection of the right that shows the LAD, and the LAD feels quite high. So I was kind of confident that we'd open the LAD. So first you do the first non-CTO PCI of the circ, and after that you do the second non-CTO PCI of the RCA. And you'll see on the dual injection, it's actually a very, very simple CTO to do, very short, single wire. This is I did this last week. This was one of the first few cases I did with the turnpike spiral catheter that you've got a clockwise. It's an interesting catheter. And complete revascularization. This is a case where I accepted incomplete revascularization. There's a CTO of the RCA, and you see there's also a CTO of the mid-circ. The circ provides collaterals to the RCA close to the onset of the CTO. The LAD is patent, and there's a diag lesion. Now, the LAD and the diagonal were quite calcified. I did not want to gel the LAD by treating the diagonal. I did not want to injure the collateral of the RCA by treating the circ first. So what I did here is I just went straight for the RCA CTO. This was a kind of a nice case to do. This was a case was done. I did this last year. That was the first time I had used the Gaia wires, very interesting wires. It helps you basically navigate within the plaque over a long segment. And so Gaia second goes somewhere. I felt here that I was suboptimal. So what I did is actually brought the crossbar, spin it, but then I couldn't spin further than this at that point. So then I put a pilot 200. The pilot 200 ran into a branch, and eventually went into the real vessel. So this is the final. Another case here. So this is a gentleman that actually refused CABG. He has a CTO of the LAD. His circ is non-obstructive. We'll see the CTO there. The LAD kind of feels faintly from the antegrade injection. There's also a CTO of the RCA. The RCA receives collaterals from the circ system. And you see that the RCA has a big epicardial conus branch to the LAD. So we do the dual injection, and then we have to decide. I did this case with Stéphane Rinfret. We needed to decide which one to go first, and we kind of changed our strategy. We decided to go to the LAD. We thought it was a bit safer to go to the LAD because it was not providing collaterals to the RCA. So what we did is just wire escalation initially with a Filter XT. Then a Gaia second that goes underneath the LAD. We're trying to find a position to re-enter at that point. We put a Stingray balloon, but you see the Stingray balloon is kind of far from the LAD, so it's probably in the branch at that point. I'm not sure in the vessel structure. So then we switched to the RCA. So in the RCA here, we used the Gaia wire. The Gaia wire was going somewhere, but subintimal. And on this, we brought the Corsair catheter to position ourselves to a re-entry position. And the Stingray balloon is inflated there. You see that the distal vessel is kind of small. We had a bit of a hematoma. We had to aspirate a little bit to make the distal vessel bigger. And this is basically a film showing that we're accessing the distal vessel through the side port of the Stingray balloon. So we got an excellent result of the RCA. So while we were there, we said, well, let's see if we can connect to the LAD. So because we had opened the RCA, so we just surfed retrograde with the cyan wire, and the cyan went all the way to the LED. So you basically confirm your position of the wire in the LED, and bring the Corsair up to the distal cap. Then you put a couple of wires to protect the circ as well as diagonal. We put a guide liner to basically isolate the LED. And here from the Corsair, you see that the wire is in the aorta, and then we pull back our wire, and the wire goes into the guide liner. The guide liner is connected to the guide catheter, and the guide catheter is connected to the other wrist, essentially. So after that, this is an antegrade procedure. But what we've got to do is, because the wire that the septal that we used to connect to the LED is quite high, you've got to put a wire into the LED. So you put the twin pass catheter and near the origin of that septal, and with the other port of the twin pass catheter, you deliver a wire into the LED, and you proceed with just basically ballooning and stenting. I'm going to show you here one last case. This is a gentleman that was treated yesterday and today, this morning. So I'm going to show you what we did. He's got a functional CTO of the circumflex. The circumflex is actually, seems a bit small there, especially for bypass surgery. He's got this LED lesion at the level of a big diagonal. And from the right, you see that there's a lower OM that is collateralizing. So basically my surgeon, Emmanuel Moss at the Jewish, did a robotic lima to the LED yesterday. You see the chest tubes are still in. So basically our protocol is that the next day they come to the lab, left radial access. We basically shoot the lima to see if it's patent, if there's good flow, and there's excellent flow there. So at the same setting, I got access to the right radial. This is dual injection. I was able, with one wire, basically, and a microcatheter, to position the vessel into the lower OM there. And we got a successful result. So this is basically an example of a successful hybrid lima to the LED, robotic, DES to the other vessel, and no vein were utilized. So in conclusion, CTO and multi-vessel disease, first, you need to determine your goal. Is the goal complete revascularization, or incomplete revascularization is acceptable? And then anatomy dictates the sequence of action, whether you will start with the CTO PCI or the non-CTO PCI. And remember, there's limited effectiveness of vein graft to treat CTO, and in doubt, think hybrid. That's it.